சார் ஒரு 5 மினிட்ஸ் மட்டும் சார். இன்னும் 2 டாக்டர் ஜாயின் பண்ண நம்ம ஸ்டார்ட் பண்ணிடலாம் சார்.
ஓகே, ஏன்னா இப்பயே 11:35 ஆகுது. ஓகே ஓகே,
அதான் சார் 5 மினிட்ஸ், இன்னும் 2 டாக்டர்ஸ் வந்து ஜாயின் பண்ணணும் சார். அதான்
சரி, ஓகே 5 மினிட்ஸ் வெயிட் பண்ணலாம். ஓகே. Ruben, shall we start, Ruben? Because the time is 11:40.
Okay, sir. Okay, sir. Start பண்ணலாம், sir. Doctors all came, sir.
Okay, fine. Okay. Can you see my slide, Mr. Ruben? Can you see my slide?
Sir, yes, sir. Screens are visible, sir.
Yeah, yes, okay, right. A very warm good morning or good noon to everyone there. My dear friends, my dear senior colleagues, my dear friends, we are going to have a very nice session today. Today we will be having some kind of interactive session, like so that we can like share our ideas, something like that. I will try to give my experience, my thoughts about MRA and all. Today's topic will be like melanoreceptor antagonist, a boon in heart failure management. I would like to thank the CIPLA team for the wonderful opportunity. This is a disclaimer for this meeting. This is a disclaimer. And our agenda today, like the first 5 minutes, I think, Ruben, are you going to give some talk for 5 minutes, or we'll go to the presentation directly?
Sir, 2 minutes, sir. I will give some introduction about
Yeah, please give introduction. Yes, then we will start. Yeah,
so
please.
very good morning to all the doctors. So thank you for giving us such an opportunity to attend this section. So Dr. Arun Ranganathan, sir, is a senior cardiologist and assistant professor in Stanley Hospital. So doctor was well interested in this kind of academic oriented. So, and also I know personally very well about the doctors, one of the kindly person. So he's well as speaking to other doctors, like speaking to other persons. So doctor is a very kind person, and he also very great person also in terms of taking some kind of classes. So in terms of sharing some information to other doctors. So he's a very great person. So kindly over the section to Dr. Arun Ranganathan, sir. So kindly share, sir. Kindly start your section, sir.
Fine, right. Thank you. Thank you for the kind words. Yes. Now we will move to the topic per se, which is like very interesting. Our objective today is like we are going to learn certain things about these many things, like MRA placements and utilization in heart failure management. Hyperkalemia, is it really a concern in physician practice? And also we would like to create some kind of awareness among physicians about the usage of MRAs. First, this one is the heart failure global epidemiology. We can say that 26 million people are affected by heart failure across the world, and of that 1 to 2% of the adult population in the developed countries are getting affected by heart failure. And also the prevalence increases with age, because as age increases more than 70 years, the prevalence is more than 10%. Coming to the Indian scenario, the prevalence is about like 1% of the total population, and also the annual incidence is about like 0.5 to 1.8 million cases per year. And the mortality, as you see here, is like it is ranging between 0.1 to 0.16 million individual per year. So it has got a high mortality. With this, we'll move to the topic. Before going into the topic per se, I have put some slides for understanding what is heart failure staging, what is NYHA class. I know that we would have read about all these things from our MBBS days, but we need to give some update, because like the updates are always there, and this will help us in our practice immensely. First, we know that we classify heart failure into stages: stage A, B, C, and D. Stage A is one who are at the risk of having a heart failure. There is no structural heart disease. These patients, like any diabetic patient, any hypertensive patient, all these patients will be under stage A. Stage B is one patient who has got some structural changes in the heart. For example, you do echocardiography, we can concentric left ventricular hypertrophy, then the patient becomes stage B. For example, left atrial enlargement, grade 1 diastolic dysfunction, all these people will be under stage B. But these patients do not have any symptoms. Coming to stage C, these are the patients who have got symptoms. So this patient will have breathing difficulty, shortness of breath. These patients could also have some other problems like angina, palpitations, giddiness, all these things can be there. This patient can have volume overload, pedal edema can be there. All these things can be there in stage C. Stage C is the end stage, it's the advanced heart failure stage. And just we have to know about NYHA, New York Heart Association class 1, 2, 3, 4 is there. There is no limitation of physical activities class 1. Class 2 is a slight limitation, and class 3 is a marked limitation, and class 3 is symptoms are present at rest. So we should have a basic understanding about this. And this is one more important classification, because all the patients, whatever we are seeing, we refer for echocardiogram. In echocardiogram, they give ejection fraction. Therein we can see the ejection fraction. Some patients will have ejection fraction less than 40. They are known as the heart failure patients who have got a reduced ejection fraction. If the ejection fraction is somewhere between 41 to 49, it is called as mildly reduced ejection fraction, and more than 50% is known as preserved ejection fraction. And fourth, the last one, that is like some patient could have got a ejection fraction less than 40, and with the treatment, the ejection fraction could have improved more than 40. It is called as improved ejection fraction. That is heart failure with improved ejection fraction. These are some various terminologies which you will come across in your daily practice, and this also helps us in choosing drugs. Okay, we'll move to the first one. What percentage of heart failure patients approach you in NYHA class 2, 3, and 4? How many heart failure patients goes undiagnosed in India at an early stage, and what is the reason? And second question also I would like to top up here. What are the diagnostic and prognostic tools used by you for heart failure patients? I would like to require the senior physicians here, my dear friends there, to give their opinion, because Mohan sir, tell me about your opinions, sir. In your daily practice, sir, how many heart failure patients you come across, sir?
So as such, heart failure definitely off late only, probably say around 5 to 10 years before only we are talking. Previously, just we diagnosed and then we gave treatment. Off late only for the past 5 years, we talk more about heart failure.
Heart failure. Yes.
Generally, if you see some of the patients who are obese, they do complain of, say, sir, gasping, I can't climb steps and all. Yes, but as far as the diagnostic and prognostic tools are concerned, since this is not routinely used by a physician, basically, yes, we do not know much about how to proceed further. Like, yes, basically, unlike your skill, heart failure, we do not go. We go, in and out of the diabetes and other echocardium.
Yes, sir. True, sir.
Till that stage only we can go, sir. Further, we don't.
Yes, sir. Yes, sir. Wonderful, sir. Wonderful, sir. Raja, sir, anything you want to add, sir? Anything you want to tell us, sir? Unmute, sir. Unmute and talk, sir.
Yes, sir. Good morning, sir.
Yes,
sir. Heart failure patient, stage 3 and 4. It's commonly around 3 and 4. It's less common only. It's commonly on the 40, around 20 to 40%. It's 20%. Around 20% it will be there in the heart failure patients. That maybe the early stage we are mostly underdiagnosed only, because unavailability and patient stigma is there. That's all the things, and early stage we are not recognizing. Some patient, most of the patient will come with symptomatic only. So most of the patient symptomatic, after symptomatic only we are diagnosing. Regarding the diagnostic and prognostic tool in the heart failure patient, routinely we are doing the renal parameters and LFT and PNP and pro-BNP, NT-pro-BNP. So this all will be the X-ray, ECG, and echocardiogram. This all will be the early diagnostic and the prognostic also. So depends on echo and pro-BNP and other things. So all will be the prognostic indicators.
Excellent. Excellent, sir. It was a very nice input. Raja sir has nicely summarized, what are the things what are the investigations we need to do for making a diagnosis of a heart failure. For making a diagnosis of heart failure, basically, we have to approach like this. First, the symptom analysis, we need to make symptom analysis. Symptom analysis means, according to Framingham's criteria, a lot of symptoms and signs are given for making a diagnosis of heart failure. For example, we may not be able to by heart all the things. We need to be more clinical and more applicable. Like when you're sitting in the room, we cannot by heart things. We should have some kind of practical approach. For the for my junior colleagues and all, I would like to tell about these important points. One is more important thing is like, no, first you need, when the patient steps inside, to start examining the patient from head to foot. From the symptoms point of view, you would like to ask about breathing difficulty, which is very important. And you have to ask about leg edema, pedal edema, that is very important. These are the two important catchy points we can pick up, like, no, from the clinic room actually. When the patient turns breathing difficulty, we have to probe one step further. It means that the breathing difficulty means you get breathing difficulty while doing regular activities. Because before and all, I used to climb 2 floors. Now I am not able to climb even 1 floor. It means that he has developed breathing difficulty. For example, a patient will be even telling like this. For example, I was very well, so I used to cycle and go. I used to walk along the street for like 2 streets. I used to walk. Now I am not able to even walk for like 100 meters, something like that. These are the symptoms of breathing difficulty. When a patient has got a breathing difficulty address, it's quite easy for us to make one like, no, this patient has got some problem. So that is very easy for us. The next important thing is like, no, look into 2 important points. One is look at the legs and look at the neck. Look at the legs. If you look at the legs, if you find pedal edema, it is very important. Like, no, we have to find something more in that. Second thing is look into the neck, right internal jugular vein. If you see some engorgement of veins itself, like, no, looking into the JVP and measuring the JVP, all these things are not really practically possible for every patient. For that, positioning the patient at 45 degrees, all these things are meticulous things are there. You will keep things as simple as possible. The next important things, look for the engorged veins in the neck. Any engorged veins in the neck, no, look like systemic venous congestion is there. So we need to make an idea like, no, something is wrong, something wrong is happening in the heart. Next, coming to the auscultation point of view, like, no, if you are able to pick up like a tachycardia is there, if you make anything like tachycardia anywhere, any place, you need to be careful. That could be a sign of heart failure. And we have to auscultate the lungs. We can make out like lung tractals and all. If it is there, we can pick up. If you are audaciously like, no, able to auscultate, we can pick up LVS3, the third heart sound can be picked up. So these are some basic methods of like, no, as a clinician, we can pick up something in the clinical chamber. And apart from that, like Dr. Raja has nicely explained about, we have to do a renal function test, liver function test, ECG, and echocardiogram to find out what is the ejection fraction, and any chamber enlargement is there. All these things will be helping us to make. So with this knowledge, we'll move to the next step. And this is one important slide wherein like, no, we can, this is the the most important slide of like, no, to manage any case of heart failure. If you see here very carefully, like, no, there are 4 important pillars in the management of heart failure. These are all some recent guidelines. These things would not have been there when we studied and all in MBBS, because, no, we used to tell about digoxin, all these things are there. These things are not much given importance nowadays. The most important thing is like, no, whenever you make a diagnosis of heart failure, the first agent to start is a AC inhibitor or a ARNI. ARNI refers to like, no, the sacubitril valsartan combination, right? The second agent we should try upon is beta blocker. The third agent comes the MRA, today's topic. The fourth important agent, like, no, SGLT2 inhibitor, that like, no, many of the practicing diabetologists will be aware of this, and more so SGLT2 inhibitor has become a drug of heart failure nowadays. So these are the 4 important pillars for managing any case of heart failure. Apart from that, when there is volume overload, we have to give diuretics. And the case becomes complex, like, no, when the ECG changes are showing some left bundle branch block, and a lot of things are there, a lot of steps are there, going for like ICDs, going for like valve replacement therapy, CRT, ICD. These things are like, no, different kind of topics. So we will stick on to the medical management right now. So the 4 important pillars we need to remember, and then diuretics according to the volume status of the patient we need to administer. All the green boxes are giving a class 1 indication. This is like, no, the AC inhibitors, the beta blockers, MRAs, they are all class 1 indicators. It means that they have to be given. And the yellow ones, no. So if you see carefully, like, no, digoxin and all is coming under like atrial fibrillation management only, because nowadays we are not using digoxin in the like, no, in heart failure patients directly, right? So these are the various things we need to understand from the slide. And I would like to like, no, put your focus on the this is one important thing. As we discussed, for the heart failure patients, reduced ejection fraction. Heart failure with reduced ejection fraction means EF less than 40%. EF less than 40% becomes heart failure with reduced. MRA has got a class 1 indication. Yeah, the mid-range or the mildly reduced ejection fraction. If the ejection fraction is somewhere between 40 to 49 range, less than 50. this becomes mildly reduced ejection fraction. Here it becomes a class 2B indication. Here also we can use, but it is a class 2B indication. So these are the two important categories wherein there is an indication for using MRAs. And we know that during for physiology days, we know that ACE inhibitors act converting of enzyme of angiotensin 1 to angiotensin 2. And we know that the angiotensin receptor blockers like valsartan, telmisartan, all these things act at the AT1 receptor level. And importantly, our interest today is aldosterone. The aldosterone inhibitors, the MRAs are put here. That is the MRAs, the mineralocorticoids will cause sodium retention, they will cause water retention, and they will push potassium outside the body. And because of this, we want to prevent sodium retention, we want to prevent water retention. For that sake, we are giving MRAs. At the same point of time, sodium is, when we give MRAs means spironolactone and eplerenone. When you give MRAs, sodium retention is prevented, water is pushed outside the body, whereas potassium retention takes place. And this is what the important mechanism of action of this aldosterone antagonist. And I would like to compare spironolactone versus eplerenone. Both are wonderful drugs, both are used extensively in clinical practice. And spironolactone, these are the properties of spironolactone, and it has got a high plasma protein binding, more than 90%. Whenever there is an increased plasma protein binding, the half-life of the drug will be more. So for that sake, when it is higher means we can give even as a once daily dosage. But usually we advise twice daily, even it can be given as once daily dosage. The active metabolite, it is not dependent on CYP system, whereas eplerenone is dependent on CY3A4 system. This is very important. If you note the MRA affinity, eplerenone has got a higher affinity because it has become a more selective agent when compared to spironolactone. And these are the various things like the anti-androgenic action is one of the most important side effects of these drugs. It is much more pronounced in spironolactone when compared to eplerenone, and hyperkalemia is also more pronounced in spironolactone. And worsening renal failure will be much more with spironolactone when compared to eplerenone. These are the various salient points in which we need to understand about these two molecules. And coming to the other important points, which I've already told, the side effects, gynecomastia, impotence, and loss of libido are more pronounced in spironolactone, and eplerenone is very much less common. In women also, some kind of menstrual irregularities, loss of libido can be there when you use spironolactone, whereas with eplerenone, it is not there. These are the various important differentiating points between spironolactone and eplerenone. And coming to the guidelines, how to start and when to start. The important point is, whenever you want to start MRA, two important parameters you need to check upon. One is the potassium level, second is the creatinine level, and by means of which we can calculate the eGFR. If the potassium levels are more than 5, we need to be very cautious. And if the creatinine level in a men, if it is less than 2.5, we can start. In women, less than 2, we can start. And eGFR should be more than 30 for this molecule to be acting nicely. So we need to monitor the potassium level. We need to find out what is the serum creatinine level before starting this molecule. And with this, are these parameter potassium level, creatinine level, eGFR to be tested before and after initiating MRAs? And if so, how long we need to check this one? I would like to invite the panel members for their expert opinion on this. Balaji sir, can you add some points, sir?
Good morning, sir.
Yes, sir.
Actually, in hospital, we can able to do potassium and creatinine level and eGFR, sir. Yes. But in a clinical practice, in clinic, it is very difficult to do all these parameters before starting or initiating the drugs.
Yes, sir. Yes, sir. True, sir. Yes, sir. Dinesh, sir, can you add some points, sir? Dinesh, sir, your experience, sir?
Yes, it is the same thing, sir. So in the clinic setup, no, sir, when we ask the patient to do all this, they don't, most of them, they don't return back. So,
return back. Okay.
Okay. So that is the difficulty which we face in a clinic setup.
Okay. Yes. Mohan, sir, you want to tell anything, sir? You will have a lot of experience, sir.
In CKD patient, definitely we do electrolytes, sir. And creatinine once in 3 months, we advise the patient. We insist upon the patient. Initially, they don't accept. But still, since you are CKD, we have to closely monitor. Otherwise, we will lead to complication. Majority of the patient will listen if you spend extra time, and then we explain this thing.
Okay. So the most important thing is like, whenever we want to start this molecule like aldosterone, or if you want to start aldosterone, or if you want to start eplerenone, when you want to start aldosterone or eplerenone, basically we need to understand what is the renal function. Without the knowledge of renal function, we cannot blindly start, because we may get like fired back. Because for example, a patient will have diabetes, diabetic kidney disease, creatinine will be like 3, like that. We may not understand that. That patient can also have a heart failure. When you blindly start the molecule, like the potassium level will increase, and the patient will land up in like ICU, like that. So the basic thing is like we would like to like make the patient understand that this is an important molecule that we have to start for heart failure. For starting this molecule, we need to understand what is the renal function, and we have to request the patient to get it done. Without this knowledge, I think we should not go ahead and start the molecule blindly. And if the patient has got any prior values like normal renal function, if the patient has undergone a mast cell checkup, anything like that, the knowledge is there, it becomes easy for us. We can start this molecule easily in those kind of patients. And with this knowledge, we'll move to what is the real guideline things, and let us update our knowledge on this. As I've already mentioned, the eGFR should be more than 30 for starting this molecule. For a men, the creatinine value should be less than 2.5. For women, the creatinine value should be less than 2. And potassium value should be less than 5 for starting this molecule. How do you start? For eplerenone, the starting dosage is like 25 milligram once daily. For spironolactone, you can start at even 12.5 milligram. The usual dosage available is 25 milligram. We can start half OD dosage also. And we need to upgrade every 2 weeks. We can step up the molecule from 25 milligram to the maximum dosage of 50 milligram we can reach. That is we can go 25 milligram BD dose like that. For spironolactone, we can go for 25 milligram BD, or we can even give 50 milligram once daily dosage also. So that is also available. And eplerenone also we can give 50 milligram once daily also. So this is the way we have to start the molecule, and after 2 to 4 weeks we have to reach the upper dosage values also. If not possible, if we are not the patient is feeling better, and you feel the upgradation of dosage is not required, you can even stick on to low dosages also, because low dosage also will have elements, benefits can be there. But given every chance, we have to go for the upper dosages. The next important point is serum electrolytes, how we have to see and what should be done in the next. You are starting a patient with say aldosterone, or you are starting with eplerenone, anything like that. We need to monitor serum potassium levels particularly. You can even simply ask for serum potassium level, and what is happening to serum creatinine. Just choose these two alone. According to the guidelines, it tells that we have to do after 3rd day, after 7th day, and every month for the next 3 months, and after that every 3 months. This is the guideline from the ACC. But practically, these many times if we ask the patient to do, patient will suspect us, and many patients will not do that. For that sake, my simple approach will be one baseline value we can do after 1 week or 10 days, just do once. If you find that potassium levels are not increased, and if you find that the creatinine values are not increasing, at that point of time, we can be relaxed that this patient is accepting this molecule, and there are no changes happening in the renal function. There are no changes happening in the electrolytes. So we can stick on with that. After that, we can try after a month's time whether something is happening. And apart from these values, lab values, the most important thing that I would like to stress upon is look at the patient's face. If you make out some facial puffiness, put forward this particular question that after getting up in the early morning, do you get any puffiness of face? This is one of the most earliest signs of renal failure. You're starting with aldosterone, you're starting with eplerenone, and if the patient tells as soon as I get up from my bed in the morning, I could notice some kind of facial puffiness, it is an early sign of renal failure. And many times this pedal edema, all these things could be appreciated even later. The first sign to happen is the early morning facial puffiness. So if you get this point, you should definitely insist upon the patient to do a renal function test to find out what has happened to the creatinine value and what has happened to the electrolytes. This is what we should know. And with this, we would like to move to the other questions. In what percentage of patients do you use MRA for heart failure management? Vasant sir, can you tell your experience, sir?
Yes, sir. Good morning, sir.
Yes, sir.
I would like to thank to the CIPLA team for this meeting, sir.
Yes.
And also your classes are very useful for us, sir.
Thank you. Thank you.
It is possible the team of CIPLA will conduct at least a monthly one meeting to update our knowledge.
I think Cipla team should take notice of this, and we will have some good interactions. Definitely, knowledge of growing is very important for good practice, actually.
Yes, sir. So in percentage of what percentage of patients who are using MRS for HF management? Usually less than 25% only.
Less than 25%. Yes. Okay. Okay. Right. Dinesh, can you add some points, Dinesh? Dr. Dinesh?
So it is the same thing, sir. We also here practice the same thing. 25% we use it.
Okay.
Sir.
Fine.
Yes.
Fantastic. Yes, actually, the percentage of using MRA is like requires a kind of eye opening. It means that there should be some eye opening for starting this molecule. There are definitely a group of patients. For example, one patient is made a diagnosis of heart failure. The patient is launching your setup. When you see there is a pedal edema, patient is tachypneic, dyspneic, and you see the echocardiogram, the ejection fraction is also less. Definitely, and the patient would have done some blood tests also. And if we find the creatinine values are less, the potassium levels are okay, definitely we should institute this MRAs in from our side. We can start with a lower dose. For example, if you're afraid, we can start Aldosterone to 12.5, 25 milligram off OD, like that we can start. And we can see the response immensely, because the response of these molecules are, we can see the benefits in the couple of weeks itself, we can see a lot of benefits. So we should be courageous enough to pick up the right patients and start the dosage. For any drug, we have to start with a low dosage. This is a very important thing. Any drug, we have to start with the low dosage, and then we need to observe for 2 weeks. Many drugs, this same methodology will will be aptly applied. That is after 2 weeks, we can step up from half OD to 1 OD, then step up to 25 milligram BD, something like that we can try. And just I would like to move to the next question. When do you consider starting MRAs in patients along with ACE, ARBs, and beta blockers? When do you consider starting? Raghu sir, are you there, sir? Raghu, yes, sir. So can you give some idea, sir? What you do, sir, in your practice? Any ideas you can share upon, sir?
As told, tablet Spironol often half 40 will be better, sir.
Great, sir.
I do use it. Yes, along with torsemide also, sir.
Along with torsemide, excellent, sir. Excellent point, sir. Excellent point. Yes, sir. Yes, sir. Any other panelists you want on any points, please share the views.
Sir, I am Dr. Raja, sir. Sir, we can start MRAs if reduced, moderate or severely less than 40% ejection fraction, we can start early, sir.
Yes.
Or we can start any other AC inhibitors and ARB. Then, if not controlled with the AC inhibitors, ARB, then we can go for MRA.
Yes.
So initially we can start if it is reduced, very severe LV dysfunction is there, less than 40%, we can start directly MRAs.
Yes. Excellent, sir. Excellent. Okay. Actually, what is the best method of approaching these cases? We shall try to understand. First, you are making a diagnosis of heart failure. The first drug we should start is ACE inhibitors or ARBs or ARNIs. Any of these drugs. For example, ACE inhibitors, we have enalapril, ramipril, any of these drugs we can start. In ARBs, you have got valsartan, telmisartan, olmesartan, you have got any of these drugs you can start. And the second drug we have to start, the second important drug that we have to start is beta blocker. Coming to beta blockers, my first choice of drug will be carvedilol, because it is an alpha plus beta blocker. Carvedilol is an important drug. The next group of drugs are bisoprolol and metoprolol. All these drugs can be started actually. So the first drug to start is ACE inhibitors or ARBs or ARNIs. This is the first drug for any heart failure patients. The second drug that we have to start is a beta blocker. It can be carvedilol, metoprolol, or bisoprolol. The next third drug is only MRA. So MRA cannot be the first drug at any point of time. So the first drug is ACE inhibitor, ARB or ARNI. Second drug beta blocker. Third drug is MRAs. What are the differences? Why it is like that? Why it is like that? And according to the recent heart failure management, we can even start all the 3 drugs together. Together means all 3 drugs simultaneously. So that is also can be done. As early as in the first week itself, going in the full force, all 3 drugs launching, and even SGLT, 4 drugs all together in one smash. We can go like that. So what is the approach, sir? How to start, sir? Whether we have to start one. Whether we can go with 2 or 3 or 4 together, what is the methodology? It depends on the patient actually. It depends on the patient. For example, you are checking what are the parameters we need to look. The clinical parameters first I would like to tell upon. You have to check the blood pressure. Blood pressure is very, very important. And you have to check the heart rate. This is also very, very important. If the blood pressure is very you have a high blood pressure, it is very easy to start these molecules. For example, you have got a patient with 150/90, it is very easy. Because the AC inhibitors also will reduce blood pressure. Beta blockers will also reduce blood pressure. Your MRAs also can reduce the blood pressure. And also these patients will be having volume overload, will be giving diuretics like Lasix, furosemide or torsemide you will be giving. So that also will reduce the blood pressure. So blood pressure is a very important parameter. For example, if you are having a BP of like 120 or 110/70 or 100/70, it becomes very, very difficult. In those patients, we need to start a single agent. We can choose between AC inhibitors, first drug, second is the beta blocker. We choose this very small drug. For example, even Ramipral 2.5 milligram, you are not able to start. We start with 1.25 milligram. For example, Carvedilol, it is available like a 3.125 milligram. You start half milligram BD like that. To start with, I'm telling. Let's try it slowly escalate. And if the patient has got symptoms like the patient has got breathing difficulty, the patient has got pedal edema, those kind of patients definitely we have to give furosemide or torsemide. Because symptom relief is the most important thing that will bring the patient to your chamber once again. And you are you're following the giving Lasix, or not giving torsemide, you're not giving furosemide, the patient will not come back. For example, you give tablet Lasix 40 milligram off 0 like that. You split the Lasix and give. And you can, if the patient is tolerating, give 40 milligram 100 like that you give. Or if you want to give torsemide, you give tablet Dita 10 milligram 100 like that you give. The patient will be definitely relieved of symptoms. The next 3 days will come back to you. So my pedal edema has come down, my breathing difficulty has come down. So you need to remember these important key points while practicing. So diuretics should definitely there if the patient has got symptoms, and AC inhibitors, beta blockers, and MRA should be the adding of lines. This will be the adding points, and it can be simultaneously possible. If possible, you have to give this. This thing could be the better approach. And with this, I'm going to one interesting physiologic concept that is called aldosterone escape. This is very interesting. So I told that AC inhibitors should be given as the initial drug. When AC inhibitors are giving, or example, you are giving ARBs, something like that, anything you are giving, or you're giving ARNIs, sacubitril valsartan, ARNIs you are giving, those things, any drug you are giving. What has happened? Initially, what has happened? When you saw the structural diagram, wherein many steps are involved, when this AC inhibitors are given, this aldosterone, the next step of aldosterone, renin angiotensin aldosterone activation, this step is there, the steps the aldosterone production is the initial point of time, it is not produced. So aldosterone, it is not produced. But after some time, because of potassium mechanism of action, potassium ion action, the aldosterone becomes more. So after starting AC inhibitor, aldosterone becomes more. And because aldosterone becomes more, the real benefit of this AC inhibitor is not obtained. So whenever you start AC inhibitor, after some time, the AC inhibitor action also will come down. This is also another important point. So the two important points I would like to stress in aldosterone escape. One is after starting chronic AC inhibitors, when you give for a longer period of time, aldosterone will become excess at one point of time. And secondly, the AC inhibitor action also will come down. In order to overcome this, aldosterone antagonist should be prescribed as early as possible. That is, we have to start either aldactone or we have to start any eplerenone as early as possible when AC inhibitor is started, so that no aldosterone escape mechanism can be prevented. This is one important learning point. This is one physiological mechanism that is given. And just moving upon to the next one, when we compare with, is there any superiority between the two molecules? Whether spironolactone is superior, whether eplerenone is superior, do you have any data? There is some scientific data coming from Bangladesh. Bangladesh have done, the Bangladesh team, they have done an important study. For 6 months, they gave these two molecules, and at the end of 6 months, they started to measure the systolic function of the heart. They found that the systolic function was better in the eplerenone group when compared to the spironolactone group. That is, eplerenone has got some kind of advantage. The ejection fraction improvement was around 6% in the eplerenone group, and it was 4% in the spironolactone group. It means that eplerenone, because of its specific action, it has got more amount of action on the heart, and the more benefit was there in the eplerenone group. This is what we try to understand. And if the patient is supported well, we have to go for eplerenone instead of spironolactone in that particular patient. Okay, when do you prefer using eplerenone and spironolactone? Any specific patient profile? This is one thing, like no high-end thing, like no many of the panelists here there, if they want to share some views, they can share upon. Satish sir, you want to add any points, sir? You want to add any point? Anything you want to tell, sir?
Good morning, sir.
Good morning, sir.
We're very glad to meet all my seniors, colleagues, and superstars of the SIPA conference. Okay. Anyway, sir, especially what I think, whenever a patient approaching me in the clinic with heart failure, I usually start with directly. I start with spironolactone.
Yes.
First of all, I will start with the spironolactone. Then I will start with the ACV inhibitors. Then I'll ask the patient to follow up me regularly after every 3 or 4 days. But I never started on eplerenone. After this session, I will start on eplerenone.
Excellent, sir. Excellent, sir. Nice. Thanks for sharing, sir. Balaji, sir, you want to share some points, sir?
So good morning, sir.
Yes, sir.
So spironolactone, we have a side effects of gynecomastia is there, sir. So we can avoid that for certain patients, so that who are prone, at least we can avoid that. For that, we can go for eplerenone.
Excellent, sir. Excellent, sir. Yes. Yes. Actually, no. If you are given a choice of choosing between the molecules, eplerenone and spironolactone, leave alone the cost factor. We will forget the cost factor. Then the choice of drug will be definitely eplerenone, because it has got a mineralocorticoid receptor antagonist action specifically. So its action is more specific. Just now, I put a comparison slide between those two, spironolactone and eplerenone. And does eplerenone have any minus points? Then that also we need to understand. Any minus point for eplerenone? For spironolactone, no, the minus points are gynecomastia. For example, no, if you treat 100 patients with spironolactone, some 10% can have this kind of gynecomastia. This is because of androgen, no, the action of androgen and the receptor level is blocked, and estrogen excess can happen. Because of this estrogen excess only, this gynecomastia is happening. This is the mechanism of action for that. And second, most importantly, the other things in women also, it can cause menstrual irregularities. Because of this estrogen excess, no, menstrual irregularities can happen in women also when you start this for heart failure. And the most other important things, the half-life of spironolactone is quite higher. It's higher when compared to eplerenone. And the advantage of spironolactone, I will tell one important advantage. The one important advantage, apart from the cost factor, it doesn't require the CYP3A4 system in the liver, whereas eplerenone requires the CYP3A4. So the other drugs which will act through this liver mechanism, CYP3A4, this metabolism, CYP3A4 system, any drugs if you are using which has got a CYP3A4 system, it can interfere with eplerenone. This is the only disadvantage of eplerenone. Otherwise, eplerenone is a superior molecule than spironolactone, because we also saw that from the Bangladesh study, the EF also improves and the left ventricular systolic function improves. And just I put this slide for just understanding purpose. Herein we can see that the advantages the minimal sexual side effects are there with eplerenone, metabolic side effects are there, hyperkalemia is less, and advantage of the testosterone is retained. And if you take the cost is one factor, and the other point that I told about the CYP3A4 system. And this is one important slide though, just we need to understand the interactions when you start with eplerenone. And commonly this is acting through CYP3A system. We need to understand the inhibitors of the erythromycin, clarithromycin, diltiazem, the ketoconazole, ritonavir, verapamil. These are some drugs which can be used. We can be prescribing antibiotics clarithromycin, erythromycin, all these things. This will inhibit 3A4. So this will have some interaction with eplerenone. And also CYP3A4 induces is also important. Phenytoin, patient has got CC disorder, patient is on phenytoin, patient is on phenobarbital, patient has got a tuberculosis, patient is on rifampicin, patient is taking steroids for many bronchial asthma, patient is taking steroids for rheumatoid arthritis. These things can have some interaction with eplerenone. This is some basic knowledge we need to understand, because these drug interactions we need to understand while starting eplerenone. Whereas for these kind of patients, we can put them on simply spironolactone, because it is not acting upon this. This is one advantage of spironolactone. This is one important thing we need to understand. And then we will move on to the next one. What is the preferred dosage and what is the titration about? in practices. Just we have already discussed about this. We have to start at the smaller dosage, like spironolactone of 25 milligram, like 12.5 milligram, the starting dosage, and then we have to, like, every 2 weeks we can escalate to 25 milligram twice daily, or you can go for 50 milligram once daily also, which is regard to spironolactone. Eplerenone, we have to begin with 25 milligram, and you can just step up to 50 milligram once daily. This is the titration about this. We have already discussed on this. And then this is one important thing, like MRA related hyperkalemia. If you start from the RAIL study, it was one of the landmark study which came in 1999 for spironolactone in heart failure. It came in 1999. And in the year 2003, something like that, this eplerenone came. So these two molecules are landmark, there are two important studies are there. One is the RAIL study for spironolactone, and then for eplerenone, two important studies are there. One is the EPISIS study, other is the EMPHASIS HF study. If you take this important study, we can the prevalence of hyperkalemia is standing at 9.3%. Say for approximately 9 to 10% of patients can develop hyperkalemia. Whereas if you watch deeply, we can find that this 9.4 among the 9.3%, only 50%, like say for example, 4 to 5% will be having true hyperkalemia. The rest of hyperkalemia is with or without this MREs, the hyperkalemia will be there. What I mean here is the prevalence of hyperkalemia, even though the data is showing 10%, the real prevalence of hyperkalemia will be only 5%. So even this 5% of population, we need to find out, and we need to reduce the dosage or even stop the drug accordingly. That I will discuss after some important slides. And here comes another important question. What is the percentage of heart failure patients MRA develop hyperkalemia, and do they require discontinuation of treatment? If yes, how many percent of the patients, or how are these patients managed? I would like to put forward to all the panel members. Can you share some of your experience on this, sir? Mohan sir, can you tell us some points, sir, whether you have got some experience, any difficulties you faced when starting this molecule?
I don't have much of experience, sir. As far
yes, sir. Yes, sir. Yes, sir. I think from many physician point of view, many would not have this kind of experience. But the point is we need to understand two other important points. That is hyperkalemia can be there in some 5 to 10% of the population. And when you see hyperkalemia, how do you approach? What should you do next? These are the questions in front of us. And the answer for this is, don't go into the slide and get don't think it's a very complex one. For example, you're seeing the potassium level after starting this spironolactone or starting this eplerenone. If the potassium value is somewhere between 4 to 5.5, you're safe and you can continue the same dosage. You can forget rest of things. If the potassium values are less, this is a very less scenario, the less common scenario. If the potassium levels are less, for example, you are giving 25 milligram, you can escalate to 50 milligram boldly. And if you are giving 25 milligram of eplerenone, we can give 50 milligram dyes. And if you have 50 milligram, we can increase to 100 milligram. If the potassium values are less, we can just double the dose of what you are giving. That's a simple concept. Whereas if the potassium levels are high, 5.5 to 5.9, if it is more than 6, if it is more than 6, stop the molecule. If it is 5.5 to 5.9, here also in our clinical step, we should stop the molecule. I will personally advise. But if you have got a lab facility wherein we can check the values, we can just off the dosage. For example, if we are giving 25 milligram, we can stick on to off. If we are giving 50 milligram, we can stick on to off of eplerenone. And after reducing, we have to watch the potassium values. Even if the potassium values are creeping upon, if it is increasing, just stop the molecule for a while. We need to find out, no, the patient is going for CKD, something else, something wrong is happening. We cannot give the molecule anymore. You have to stop the molecule. Whereas if the potassium levels are coming down to the normal value of 4 to 5.5, or even if it is reducing, we can maintain the dose, or you can even increase the dose after 2 weeks time. So simple thing is, I would like to repeat the same thing once again. The values are between 4 to 5.5, no dosage adjustments required, go for whatever you are doing. If the values are less than 4, you double the dose. For example, 12.5 to 25 or 25 to 50. The same way you can adopt for eplerenone also. If the values are high, more than 6 or even more than 5.5, 5.8, 5. Anything like that, try to stop the molecule, reassess after some time what is happening to potassium values. The potassium values are still very high, we cannot start the molecule at any point of time. We cannot give the molecule. Whereas the potassium values are like come to the normal range or coming to the lower values, we can restart the molecule once again. This is the way we need to adopt while starting this, and this is the way forward we have to go about with potassium values. And coming to the most important thing, like timing, when do you start and how do you start, which is the best period to start? This is the thing. If this is trial, landmark trial, which came in 2003, it tells that if you start the molecule after acute myocardial infarction, the days between 3 and 7, that is less than a week, if you start this molecule, if you start in acute MI patient less than 7 days, the benefit is like the mortality rate is reduced by 30%, 34% actually, 34%. So the mortality benefit is very much when you start the molecule at an early period of time, say less than 7 days of acute MI. Whereas you start the molecule like very much later, after 2 months, 3 months, the benefits are not that much. So if you start the molecule earlier, the benefits are more. This is one comparison. Herein we can see that the mortality benefit when it is started earlier, 31% reduction in mortality, all-cause mortality, and also in sudden cardiac death is also reduced by 34% when it is started earlier. So the point of understanding here is, if you start the molecule earlier, the benefit is more. In clinical practice, how early are MRAs initiated for the management of heart failure? I would request any panel member here to share upon their views. Dinesh, sir, can you tell some points? Can you add any points, sir?
In clinical practice, how early are MRSAs initiated for management? Actually, I'm not so confident in answering this question.
Yes. I think many practicing physicians, this may be a difficult question. Because they will be saying many patients in a clinical setup. In this patients the earliest starting of MREs is quite possible only in the hospital setup, in ICU setup. The point here is we can gain this knowledge. That is the knowledge that we are going to gain is MRE should be started as early as possible in less than 7 days. If you start less than 7 days in acute MI patient, the benefits are rarely when you come across a patient who sustained an acute MI treated at any hospital, the patient is launching in your clinic, and you see the patient, you're looking for the drugs, whatever the patient will be having a ACE inhibitor, the patient will be having a beta blocker, and you see the ejection fraction is less than 40, and we need to find that MRA is missing in that. So at that point, you will get an opportunity to start MRA. This is one important point that I like to convey. And coming to this, this is the scenario of managing any heart failure. First, ACE inhibitor, beta blockers, MRA, and dapagliflozin and empagliflozin are the two important molecules which are we can start. The advantage of these glyphosins, irrespective of the blood pressure, the hemodynamics of the patient will not be coming into consideration. Irrespective of the BP is high or low, definitely we can start these molecules because these molecules will not reduce the blood pressure. Whereas the ACE inhibitors, ARNIs, beta blockers, MRAs, they have a tendency to decrease the blood pressure. This one point with regard to the hemodynamics. And other important point is all the four important pillars, ACE inhibitors, ARBs or ARNIs, beta blockers, MRA, dapagliflozin or empagliflozin. And next is the loop diuretics. With regard to the loop diuretics, the most important point that I would like to share my view is loop diuretics can be given to all patients who have got a volume overload who are symptomatic. And you are treating the patient, 3 weeks gone, 4 weeks gone, the patient becomes better, and the patient is now, there is no pedal edema, there are no engorged veins in the neck, and the patient tells that, no, I am better now. There is no breathing difficulty. I am able to climb 2 floors also at PTs. At that point of time, we can stop the loop diuretics. This is one important point that we need to understand in heart failure management. Loop diuretics need not be given lifelong, need not be given continuously. The important thing is the more important drugs, the 4 important drugs that I mentioned, those 4 drugs should be there. Whereas loop diuretics can be treated for example, when patient has got fever, you are giving paracetamol, fever is gone, we stop paracetamol. Similarly, loop diuretics can be given only based upon the symptoms. That is, when there is volume overload and when the patient has got a breathing difficulty. And when the volume overload is vanished, when the patient's breathing difficulty has decreased, we can stop the loop diuretic. Because aldactone is another important drug that you are given, or epinephrine and important drug. So those 4 molecules are sufficient. Even this dapagliflozin, empagliflozin, they have got some diuretic action also. So many times, we are giving Lasix or we're giving furosemide or torsemide continuously because the notorious action of this loop diuretics they can cause hypokalemia, they can cause dehydration. And they can cause interference with the other mechanisms also. So we need to understand this. So loop diuretics need not be given for a prolonged period of time. This is the most important point that we need to understand from this. Next, we are moving around. And at what stage of heart failure, diuretics and MRA both are needed? This is very interesting. We have been talking on this. And what is the preferred choice? Eplerenone alone, eplerenone plus torsemide, spironolactone alone, spironolactone plus torsemide. I request the panel members to share their views. Mohan sir, can you share some views, sir? You will have some experience on this, sir.
Not much of an experience, sir.
Okay, sir. Okay. Any other panel member? Anyone there? Yes.
Sir, patient present with the symptomatic, we can use on the diuretics and MRA, or severe ejection fraction less than 40. We can use both MRA and diuretics.
Great, sir. Yes, sir. Yes.
Sir, if needed, if there is a need, we can add a torsemide. Otherwise, eplerenone alone is enough, sir.
Great, sir. Yes, sir. Okay. Any other panel member would like to share their view? Anyone there?
Sir, as you told earlier that a stage C and stage D patient having symptomatic can use both diuretics and MRA, sir. It will be very useful for them. Yes, sir.
Yes.
So thank you.
Thank you. Nice of you. Yes. I think I would like to put an answer for this. The thing is whenever you see a heart failure patient with volume overload, start both the molecules. Start torsemide, start eplerenone, or start torsemide plus spironolactone. So the rule of thumb is patient has got a volume overload, definitely loop diuretic should be there in place. That is, we need to start torsemide, we need to start. And eplerenone, if the patient is dry, we can start only eplerenone or spironolactone, either of the drugs. So the patient's real assessment of the patient needs to take place in our clinic. We have to look for volume overload signs. The patient has got pedal edema. The pedal edema can be even extending up to the knees. It can be there. Some patients can have ascites also. And if you press the patient can have a congested hepatomegaly. So the liver congestion could be there, and the engorged veins can be there. So you have to look for these cardinal signs. These are very important signs. When you see these findings, we need to start torsemide plus eplerenone or torsemide plus spironolactone. This should be the combination. And after a period of time that I've just explained, after some, say for example, 3 weeks, 4 weeks, after a month, when the patient is coming for review, you see that the patient pedal edema has decreased almost quite normal. And if you press the epigastrium, if you press the right hypochondrium, the hepatomegaly would have reduced definitely. The engorged veins would have come down. So in those patients, we need to withdraw torsemide. So we have to put only eplerenone or spironolactone. Either one drug should be there. The other important point of caution in managing this patient is, the most important point is in these times, the summer times, patient will go for dehydration themselves. When you put large amount of torsemide or furosemide in these kind of patients, it would add more woes to the patient. It becomes more difficult for the patient. And whenever patient develops a kind of diarrhea or vomiting, this loop diuretic should be withdrawn. These are the various important points. When a patient presents to us, have you developed any other problem? Do you have got any other thing you got diarrhea, you got vomiting? So at this point of time, we need to be cautious. We need to withdraw the molecule. And second, most importantly, if the patient has got a diarrhea, vomiting, all these things we need to check the renal function, because the patient go for acute kidney injury. At those point of time, we need to withdraw eplerenone. We need to withdraw spironolactone. So this is very, very important. So we have to be doubly cautious. When a patient develops a new problem, we need to reassess the molecule once again. We have to withdraw the molecule for a time while, and we can restart later. These are the small tips and tricks we need to adopt in our practice. And then we'll move to the next one. I think we are going for a Sunday afternoon, we are stealing the time of many. Our precious time is, many of them will be to spend the time with the family, And we are coming to the final part. Is there any other indication for using MRAs? What scientific initiatives would you suggest for CIPLA for increasing awareness among CP? We'll come to the 14th question last. What are the other indications of MRA? This is very interesting. This is very, very interesting. Is there any other indication for using MRAs? I think the treating physicians would have a lot of knowledge about this, because many of them would be using for this liver cell failure. Balaji sir, can you add some points, sir?
Yes, sir. For the DCLD patients, we are using
Excellent.
spironolactone, sir.
Yes. Rajesh sir, would you share some points, sir?
Yes, sir. For decompensated liver disease, and it's also have the anti-hypertension. Some more BP
Fantastic
come
point.
down, and
Yes.
also some more renal protection. Renal protection in proteinuria patients. Some
Yes.
have renal protection also.
Excellent
So
point, sir. Excellent, excellent, sir. Excellent experience, sir. Yes, sir. Anyone, sir? Anyone? Raghu, sir? Anyone? Any point you want to add, sir? Raghu, sir?
Sir, excuse me. Recently,
Nothing new,
one
sir.
patient.
I think some technical difficulties are there, I think. Yes, sir. I think Raghu sir has got some technical difficulties. I think we will allow sir to talk after some time. Just I would like to share my views on this. The important thing is like, no, we know that heart failure, class 3, class 4, definite class 1 indication for starting this molecule. Very, very important. And Rajesh sir also told about this, this hypertension. What is like, no, which group of hypertension we need to start? This practical tips can be useful for you. First one is like, no, in hypertension patients, generally like, no, in any kind of hypertension patient, we start with like AC inhibitors, ARBs, mainly ARBs we start. And we start with calcium channel blockers. And also one kind of diuretic should be there. It can be any thiazide type of diuretic, chlorothiazide, like no hydrochlorothiazide or chlorphalidone, or it can be indapamide, anything should be there. After starting three molecules, you started one ARB, you started one CCB, you started one diuretic, whatever I mentioned. In spite of these molecules, if the patient has got a high BP, the patient is defined as a resistant hypertension. When one patient is not, one blood pressure is not controlled with 3 agents, when a 4th agent is required, the patient is termed as resistant hypertension. In those group of patients, this aldosterone is a wonderful molecule. This aldactone is a wonderful molecule. At this point of time, I do not find many studies with regard to eplerenone. Definitely no, this spironolactone has got an indication. So spironolactone can definitely bring the BP when the BP is not controlled with the 3 molecules. So this is one important thing. And liver cirrhosis, as many of the panelists have explained, liver cirrhosis definitely when there is a ascites, volume overload, definitely we give aldactone. And also in nephrotic syndrome, we used to give aldactone because it has got some fibrotic actions are there. The important thing is like the different kind of action which I would like to tell about this aldactone is it's got an anti-fibrotic action. Because of that only left ventricular remodeling becomes decline. There's some called reverse remodeling, we call that. Anti-fibrotic action. Similarly in kidneys also this anti-fibrotic action is there. Apart from this melanoreceptor antagonist action, they have got anti-fibrotic action. This is the second different action they have got. So they have got a benefit in reverse remodeling. And apart from that, primary hyperaldosteronism, this molecule is used. This is very, very rare, hyperaldosteronism. This like some patient who have got adrenal tumors. You do a CT scan of the abdomen, you do ultrasound, suddenly no suprarenal mass will be there. In those patients, we need to suspect hyperaldosteronism. In those kind of patients, spironolactone is useful in this kind of patient. These are the other indications for that. With this, I would like to put some this. What are the scientific initiatives would you suggest for CIPLA for increasing awareness among this? Mohan sir, you are a very senior physician, sir. Sir, what you would like to say is just some points for improving the what should be done, sir.
This initiative itself is a great thing, sir. You wonderfully presented in and out instead of the dictac lecture, practical usage that is more important in our day-to-day practice, sir. It's really hands off to you, sir. Such an initiative definitely will improve our practice and also knowledge because day in and day out we see a lot of new cases. We can't go and search in textbooks and other things. So as of you have given very useful tips in our practice and really wonderful, sir. Hats off to you and hats off to CIPLA, sir.
Thank you, sir. Thank you, sir. Thank you, sir. Dinesh sir, you want to add any points, sir? Dinesh sir. I think Dinesh is not able to. I think it's unmute. Should unmute, sir. Okay. Okay. I think some communication difficulty is there. Vasant sir, can you add some points, sir? Vasant sir.
Hello. Yes, sir.
Yes, sir. Yes, sir. Tell me, sir.
Yes, sir. Today's section is very useful, sir.
Yes.
It's really informative, sir, to update our knowledge in our daily clinical practice, sir. And thanks to you and thanks to the supply team, sir. I would like to tell one thing to the supply team. Monthly one topic, like our college CME, like if the supply will do this, it will be very useful to update our knowledge in clinical practice, sir.
Yes. Excellent, sir. Excellent. Raghu, sir. Rajesh, sir, Satish, sir, please share your views, sir. Yes, sir.
Yes, sir. Sir, very nice initiative and very nice presentations also, sir. So, very thank you so much, sir. We learned a lot of things in practical point in this, how to initiate, how to these things all. This will be very useful to clinical practice and so other people and some these things. This is very useful, sir. Like this we can do. It's a better way. It's one topics that will be better to improve the knowledge.
Definitely, sir. Definitely.
Thank you.
Yes, sir.
Thank you very much, sir. That's okay.
Sir, Dr. Dinesh here, sir. Sir, Arun, sir, thank you so much, sir. Actually, it is apart from that monotonous lectures, sir, it was very interactive session we had, and you kept us all awake, actually.
Okay.
So in between you're pointing us like a school teacher. You do finish your answers. So it was actually very good, sir. Only when that keeps us motivated to keep it listen so that we'll be able to answer the questions. So it was nice, sir. Thank you so much, sir. It was a very good session.
So we are all like, no, it's a friendly approach. No one is like, no, just we would like to share our experiences among us.
Yes, sir. Yes, actually, it was very good, sir. Everyone had his different experiences, and it was a collective information which we got.
Yes, definitely, yes.
Yes, sir. Thank you, sir.
Satish, sir.
Sir, it's a very nice topic today, and I really enjoyed it, and I really learned so many points from your side, sir. It is better to keep the CME every month so that we will have a good interaction among us and have a good learning methodology. Thank you, sir.
Thank you.
And I think add to one more point. Recently, one patient with chronic liver disease with the portal hypertension. The patient was taking a treatment from Bangalore Kims Hospital.
Okay.
After that, the patient came to his native place because of some economical status, financial status. And the patient approached my clinic. Then I saw that they didn't start at all spinal concept. They are given ACB inhibitors, ARB inhibitors. With for portal hypertension also they didn't start anything. Then I started only spiral with a low dose because the renal impairment is there. So now after the fourth day, the patient came by walk. Having such a pedal edema, he came by walk.
Yes. So fantastic, sir. Fantastic, sir. So I think have I missed any panelists? I think like no, I'm seeing them and asking. I hope that I have engaged any panelists. I'm sorry that if I have not engaged anyone there because it may not be visible in my screen. I think so. So I would like to summarize the important points in a fast manner. First important point is heart failure. Try to make a diagnosis. Clinically, try to make a diagnosis. First, look for pedal edema, breathing difficulty. Try to make a diagnosis. Whenever you made on heart failure, request for some investigations. Request them because without investigation in the modern world, we cannot treat. Basic investigations, as nicely pointed by you all, importantly, renal function test is very, very important. And echocardiogram, ECG, these things are important. Trying to group the patient in one particular group. For example, when the EF is less than 40, heart failure is a reduced ejection fraction. 40 to 49, mid-range or a mildly reduced ejection fraction. More than 50, no business of starting this molecule. It doesn't come at all. So when it is less than 40, definitely we have got an indication. The next more important, start any drug, you start in a very small dose. Even half 40 dose can be okay. Then you can increase to 1 BD, something like that. Next important thing is, even if it's not possible to do it according to the guidelines, try to do one potassium value or creatinine value after like 10 days or 15 days. And also assess the clinical status. And thereupon, like, no, if you want, you can increase the dosages. Patient definitely will get the benefit out of that. And next important point that I will like, you have one checklist. One checklist means what? What I mean is, checklist is whether the patient, heart failure patient, has got 4 important drugs. First, you look for whether this patient has got any AC inhibitor or ARB or RB. Second, you look for beta blocker. Third, you look for MRE. Fourth, you look for glycosils. So these 4 molecules should be there. So you have to institute these 4 molecules. If it is not there, you try to introduce this. This is the important learning point that we need to understand from a physician point of view. So you look for the 4 drugs, whether the 4 drugs are there or not. If anyone is missing also, is there any reason for missing? You need to find out. For example, a patient has got a kidney disease, so they missed spironolactone. That is okay. The patient has got bronchial asthma, severe bronchial asthma, beta blockers I am not able to put. That is okay. So simply like, you have to look into the simple parameters. If the drug is there or not, possible, you have to introduce the drug. That is the most important learning point that we need to understand. With this, if you want to share any other points, any specific questions people want to ask, you can ask. That I will share. After that, we will conclude the session.
What age group do we suspect, sir? Sometimes is there a specific age group wherein going for investigation or?
Yes, sir. So it's very, very simple, sir. For example, you start one patient. I'm telling about heart failure, sir. First, I will focus upon heart failure. The age group for heart failure, like, no, the patient should have got some acute MI, old MI. The patients, if you have to ask whether you had any heart attack before, something like that. If you get some flu like that itself, we have to be alert. For example, a patient would have sustained an antral MI 5 years back. But by the time, when you see the patient, no, this patient would be in heart failure. No chest pain will be there. Only heart failure will be there. So when you can, we have to find the history probing is the most important thing. The history will fetch us a lot of things. The second group that we come across is dilated cardiomyopathy and heart failure. If you see the MI and heart failure, they will be in the age group 45 plus. This dilated cardiomyopathy and heart failure, you can even see a young man of 30 years, patient taking alcohol, chronic alcoholic patient, going for alcoholic cardiomyopathy. That guy's age is only 30 years, but the patient has got fetal edema, ascites also will be there, engorged veins will be there. So history is important. Alcoholism, alcoholic cardiomyopathy, heart failure. So the age group can even be less in those groups. One small group of patients, like small chunk, that is called viral myocarditis. Because of this COVID scenario, some patients sustain myocarditis. That is called as viral myocarditis. Because of that, the patient developed cardiomyopathy, patient developed heart failure. This post-COVID scenario, some patients will be that in that group. Even a history of COVID, like will give us, did you get COVID before? Had you been as an inpatient? Had you been as an outpatient? These questions will fetch us into. If the patient has been as an inpatient, the disease would have been severe. The chance of heart failure is there. The patient knows I was only in the home quarantine. Nothing like that. So those patients will not be having that. So the age group, it depends upon the history actually. So if the young patient, we need to probe about alcoholism, the viral myocarditis, COVID, all these things. The old age group, we have to think of MI, old MI, particularly old MI. Simple approach like this will be useful, sir.
Thank you, sir. Thank you, sir.
Yes, sir.
Sir, any cutoff age will be there, from the ranges of in mid 20 or 25 or 30, like that we are like to know, sir.
Cutoff for what, sir? What?
Age cutoff factors around after 30s. Yeah.
For what disease, sir? For what disease?
HF, sir.
Heart failure. Okay. So it is the scenario is quite changing, sir. When I was
because nowadays the MIs are more common in the 25 years of age also, sir. Yes. You told that there is a previous history of MI.
Yes, this is very important, sir. Very, very important. The eye opening for this important question is the background of the patient. Heart disease does not have anything the previous times, in the 70s, 80s and all, these are non-communicable diseases. These are non-communicable diseases, and these were the diseases of the affluent people. But it is not like that anymore. Even poor people have got heart failure because of fast food culture. The most important point that I picked up is, where do you eat? Where do you take your food? This is the most important question. Most of the patients, the low socioeconomic people are taking food from outside. The fast food culture is very rampant nowadays. The fast food culture goes for early atherosclerosis and early MI. This is the most important mechanism. Apart from that, the other bad habits like smoking, alcoholism are coupling with this, and the early MIs are very common. And most important thing is the IT people stress is more common. Night shifts, BPO people, night shifts. Early, like no, they don't have any much time for sleeping in the night. So the enormous stress and the important thing, lack of sleep and lack of physical activity, this is also important. All these things coupled together and they form early MIs. So MIs are not like no, each people only get MI. It is not like that. People who are young also get MI. So we need to put forward so many questions for this. Then only we can understand what has happened actually.
Is there any correlation between the BMI and heart failure, or only obese people get heart failure, or any?
This is very interesting. It's a very, very interesting question. So the first question is obesity and heart failure. They go hand in hand. So whenever there is obesity, this patient, obesity by itself, like no, will be placing the patient under stage A or even stage B. Stage B, one slide I put heart failure A, B, C, D, no, sir. Obesity, like no, they can cause some structural changes in the heart, like diastolic dysfunction. So the patient directly goes into stage B actually. When this patient is coupled with alcoholism, coupled with old MI, this patient lands up in heart failure. So these are the important things. Coming to the thin individuals, no, this is very intelligent question, sir. In Indians, what I find is like no visceral adiposity and like no the outside adiposity, what we say. Visceral adiposity is much dangerous than this kind of peripheral central obesity. Some patients have a pot belly and they become like this. That is different. Some people will be very thin and lean. You're doing ultrasound, you come across fatty liver. Fatty liver means visceral adiposity. Visceral adiposity means this patient has got accelerated atherosclerosis and this patient has got a higher chance of myocardial infarction, higher chance of stroke, higher chance of renal failure. And similarly, when it is there, this can cause diastolic dysfunction and can cause heart failure also. So thin individual doesn't mean like everything is normal. You do an ultrasound, fatty liver is there, this guy is a risky guy. That is why we need to find that, sir.
What investigations are apart from echocardiogram? We important investigation because pro BNP and all we do not do.
Yeah, it's a costly test also.
So we want to know the cost effectiveness. Any test you want to do means what is the really important or not? What test to be done like?
Yes, it's a very important thing, sir. In an Indian scenario, cost becomes an important factor. We cannot like the patient cannot spend money in those things. We need to apply some other thing. As I told earlier, sir, the clinical examination is the most important thing, sir. Clinical examination. The next, only few tests I can do. What are the few tests I want to choose? What are the few tests which are the most important thing? My first test is like no hemoglobin. Just go for only hemoglobin. The next important test, my choice is to go for serum creatinine, blood urea, potassium. These things are very important. And liver test, if you do the whole liver profile, it is very costly. Go for only SGOT and SGPT. Don't go for bilirubin. Go for SGOT and SGPT. Then you ask for urine, like no urine routine. If you want to summarize, like no, these 5 to 6 tests, these are very catchy tests, I would call this catchy test, because you get a lot of information. And NT-proBNP, don't go for every patient because it might be costlier. You go for ECG. You go for ECG. ECG will tell like no left ventricular hypertrophy and old MI, all these important points, ST depression, all these things we can add. So these are the important parameters we need to look upon. These important key parameters like no will make us some good diagnosis. Will give us will help us to make some good diagnosis.
Where you will place echocardiogram? All patients require echo?
Yeah.
Or?
When the patient becomes like affordable, becomes echocardiogram gives plenty of information, sir, plenty of information. The first point that we get is like no ejection fraction, because like no EF less than 40 becomes reduced ejection fraction. The second important point is diastolic dysfunction. Diastolic dysfunction is also very important. The next important thing is now left ventricular hypertrophy, LA enlarge, all these parameters, pulmonary hypertension, RV dysfunction. So when patient has got pedal edema, RV dysfunction, right ventricular failure, pedal edema, we can correlate. Your correlation will becomes very clear with echocardiogram. Whenever patient is affordable, you have to go for echocardiograms.
Sir, hypertensive patient going for heart failure.
Yes,
So
sir.
as you told that resistant hypertension, we can use aldactone, sir.
Yes,
Is
sir.
there any, we can use this earlier, sir, a little bit earlier, the symptoms, the mild symptoms?
Definitely, definitely. Your kidney function is quite normal. So it is a very big playground for us to play now. When the kidney function is normal, it is a big playground to play. So whenever you feel like that, definitely no, this cannot be the first line that we need to understand. mRNAs cannot be the first line for hypertension. Our first line will be like no ARB, CCB, all these things will be the beta blockers, all these things will be the first line. And when the BP is not well controlled, we can go for that. The second important tip here is, you're seeing one patient, this patient is taking, for example, I will tell like telmisartan for the past 5 years, telmisartan. One important point that I told, chronic ARB therapy, chronic AC therapy can go for aldosterone escape. So those patients will get immense benefit. The patient will tell like, so I was taking telmisartan 40 mg once daily, the BP was nicely controlled. Now the BP is not nicely controlled, the BP is shooting up, sir. So this is because of aldosterone escape. In that patient, if you start like 25 mg of aldactone or eplerenone, I think we should not avoid in hypertension because guidelines are not favoring. You can start aldactone 25 mg or 50 mg, anything like that. It will be useful then.
Thank you, sir. Thank you, sir. Valuable point.
I think we are shooting time. I think we are gone for more than 1.5 hours. It was enormously a good thing for me to share your views. I also learned a lot of things from you people. It was a wonderful experience for me actually. Mohan sir, can we conclude, sir?
Yes, sir. Yes, sir. Yes, sir. It was really a wonderful session, sir, because being on Sunday, a lot of the doctors would have been very busy. That too, starting day of the, May month. It was really an excellent session, sir. We always cherish this day because you are given an insight so that we can read more, and then we have to update our knowledge also. As you said, heart failure being a new, but definitely it's on the increase. We see a lot of patients, diabetic patients. In spite of that, we have to take extra care. So you give valuable, very, very valuable tips to how to tackle, how to do, what investigation, that too, which patients, and also overall, it was an excellent session, sir. I thank really for your beautiful lecture and very, very practical lectures. That is all the more important because we hear day in and day out lot of virtual meetings. But this meeting is really very, very excellent, sir. I thank also CIPLA for arranging this meeting and also thank all the delegates in spite of the busy schedule. Without participation, definitely any meeting would not be fruitful enough, sir, because all the delegates have participated and also you have shared your knowledge. Sharing is more important. Instead of delivering lecture, sharing and clearing all the doubts, that is all the more important, sir. Thank you very much, sir.
Thank you, sir.
Thank you very much, sir.
Thank you, sir. I thank all the panelists for their wonderful participation. I'd like to thank the CIPLA team for their wonderful opportunity. Thank you one and all. I think we shall meet once again within another forum with another topic. Yes. Thank you, sir. Thank you, sir. Hats off, sir. Thank you, sir.
Thank you, doctors. Thank you, all the doctors, to give a valuable time to attend these sections. I hope all the doctors will get some information about Dr. Arun Ranganathan, sir. So all the doctors are saying, sir, the meeting will be, all the doctors will enjoying. So Vasanta Kumar sir and you, Mugan sir, all the doctors, every month once it will be, I mean, so people are enjoying. So definitely it's a pleasure, sir. I'm ready to do this meeting in every month once. So same doctors, we also do every month once this meeting will conduct, sir.
Yes.
Okay.
Thank you.
Thank you, sir.
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 Thank you.